So you're staring at the pre-op photos, and, rhinoplasty is arguably the most challenging, but undeniably the most rewarding procedure in plastic surgery.
Oh, completely. The margin for error is, it's measured in literal millimeters.
Right. It's not like setting a femur where the bone does the work for you.
Yeah.
You are dealing with dynamic breathing anatomy right in the center of the patient's identity.
Exactly.
So, welcome to our deep dive. Today, we are unpacking a ton of clinical data and operative guidelines on modern rhinoplasty to really uncover the precise mechanics of tissue-sparing techniques. We're going to break down how you actually execute these maneuvers in the OR.
Yeah, and to really get that, it requires understanding a massive shift in our overarching philosophy. The days of aggressive ablative techniques are just dead.
Yeah, thankfully.
Right. We used to just, blindly reduce and divide the osteocartilaginous framework. We essentially chop the nose down to size. But the modern paradigm is entirely structural. It's cartilage sparing.
So we augment, we suture, and we conserve the native anatomy.
Exactly, to build a structural foundation that looks good today and actually functions 20 years from now.
Which is the goal.
Yeah.
But before you even pick up a blade or mark an incision, you really have to read the dynamic landscape of the face. Skin dictates absolutely everything you do in the OR.
Oh, 100%.
Let's look at the upper two-thirds of the nose first. It is incredibly thin. It averages around 1,300 micrometers.
Which is nothing.
Right. It's like operating under a silk sheet. Every minor framework change, every tiny rasp irregularity you leave behind it is going to show the second the edema resolves.
It hides absolutely nothing. But then you move down to the lower third, the tip. And here, the skin is just entirely different.
It's so thick.
Yeah, it's thick, it's highly sebaceous, and it averages, 2,400 micrometers. That is like sculpting under a heavy winter quilt.
Love that analogy.
It completely hides your finesse work. You have to be incredibly aggressive with your cartilage manipulation and your structural grafting just to get any visible definition to push through that thick envelope.
Yeah, we've all seen cases where the static anatomy looks great on the table, but we forget the muscular dynamics. Here's a really common pitfall: ignoring the depressor septinaci muscle.
Oh man, I see residents miss this constantly.
Right.
In real life, during the initial consult, you have to animate the face. You have to make the patient smile or laugh.
Because if that nasal tip visibly drops and the upper lip artificially shortens when they smile,
then you are looking at an overactive depressor septi. You need to dissect and transpose that muscle during the case. If you leave it alone, you will lose your meticulously crafted tip projection the second they walk out of the clinic and smile at their family.
that's a great clinical pearl. Let's shift to blood supply. When we use an open approach, we make that transcolumellar stair-step incision. Mechanically, you are completely transecting the columellar branches of the arterial supply.
Which is terrifying the first time you think about it.
Right. And anatomically, those branches are present in over 68% of patients.
Mm.
So how do you guarantee the tip actually survives?
Well, once you transect those columellar branches, you are relying entirely on the lateral nasal and dorsal nasal arteries to keep that tip alive.
Wow.
And this is exactly why your plane of dissection is a non-negotiable step. You must stay precisely in the submusculo-aponeurotic plane.
Meaning you are right on the cartilage. You're just bearing the framework.
Yeah, you stay right above the perichondrium.
Oh.
Because if you dissect too superficially into the fat, you injure the subcutaneous veins and the lymphatic drainage network.
And then they're swollen for months.
Exactly. That guarantees your patient will have months of unnecessary, stubborn post-op edema. But if you stray too deep, you hit those vital arterial branches we just talked about.
Which is a disaster.
Total disaster. If you stay in the correct avascular plane, the dissection is practically bloodless and the tip stays perfectly viable.
So understanding the tissue landscape is clearly critical. But mastering the anatomy doesn't matter at all if you operate on the wrong patient or, misjudge the facial harmony from the start.
Patient selection is literally everything. We rely heavily on the Gorney-Graham concept here.
Right, the Gorney-Graham.
Yeah, it is a simple tool that maps the patient's subjective degree of concern against the actual objective physical deformity you see in front of you.
We have all had that sinking feeling during a consult when a patient pulls out a magnifying glass to show you a 1 millimeter asymmetry.
Oh, the magnifying glass. That is the absolute red zone.
Yeah.
When you have a patient presenting with a very minor, barely noticeable deformity, but they have a massive, disproportionate amount of psychological concern about it, you simply do not operate.
It's a total trap.
It is a trap. You will never meet their expectations regardless of the aesthetic improvement you deliver.
It's a great rule to live by. So let's walk through the clinical baselines of nasofacial analysis. We divide the face into thirds.
Right.
And when you evaluate the upper third, you aren't just looking at the hairline. You have to check for asymmetry or brow to penotsalasis that might throw off your perception of their central alignment.
Browtosis is easily missed if you're only focused on the nose.
Exactly. But let's look at the specific mathematical metrics. The textbook ideal nasal length, from the root of the nose down to the tip, should mathematically equal the stomian to menton distance.
Which is essentially the distance from the center of the closed lips down to the bottom of the chin.
Right. And your LR base width should perfectly match the intercanthal distance between the eyes.
And ideally, the bony base of the nose should measure about 80% of that LR base width.
I always struggle with teaching these numbers rigidly, though.
Really? How come?
Well, they are historically based on Caucasian female metrics. They feel entirely too rigid for a modern, diverse patient population. I mean, we can't just stamp the same nose on every face.
No, that is a very valid point. These numbers are starting points, not absolute laws. You have to individualize everything based on the patient's specific ethnicity and gender. Because over-narrowing a male dorsum to fit a textbook metric leads to a surgically over-feminized look that just doesn't fit his face. But these metrics do give you a necessary mathematical baseline to measure against.
Right, they give you a place to anchor your operative plan.
Exactly. Take tip projection, for example. Ensuring 50 to 60% of the nasal tip lies anterior to a vertical line drop from the upper lip gives you a standardized way to evaluate projection before you surgically alter it.
That makes sense.
And if you look at the alar-columellar relationship on the lateral view, you stratify any discrepancy into 6 distinct classes. Class 1, 2, and 3 describe increased columellar show, while Class 4, 5, and 6 demonstrate decreased columellar show.
So you really need this math to formulate your exact surgical maneuvers?
You do.
Well, once the operative plan is mathematically and aesthetically sound, we move into the structural execution. We usually start with the midfold and the septum. Let's talk about the component dorsal hump reduction.
Oh, this is a game changer. It is completely different from the old techniques.
Right, the old ambulatory resection is how you create surgical disasters.
Seriously. If you just take a scalpel and slice off the dorsal septum and the upper lateral cartilages all at the same time, you completely destroy the functional anatomy.
You get perfectly rounded, unnatural, washed-out dorsum.
Or worse, you get a severe inverted V deformity a year later because those upper laterals just collapse inward.
So how do we do it now? I know the component reduction is a 5-step technique, but what are the actual mechanics of the initial approach?
Well, you start by creating bilateral superior submucoperchondrial tunnels. You are basically elevating the lining away from the underside of the cartilage.
Okay.
Then you sharply separate the upper lateral cartilages from the septum without damaging that underlying mucosa.
But why is that separation step so critical? Why not just shave it all down together?
Because by separating and preserving the transverse portions of those upper lateral cartilages, you are saving the internal nasal valve.
Oh, I see.
Yeah, you are preserving the natural dorsal aesthetic lines. Once they are separated, you can incrementally reduce the cartilaginous septum on its own. Then you address the bony hump with a rasp or an osteotomy.
It gives you precise control over the profile rather than relying on a single destructive cut.
Exactly.
And verification is a huge part of this process. In the OR, you use the 3-point dorsal palpation test. You take a saline-moistened dominant index finger.
Best tool in the room.
Really is. You run it carefully along the left dorsal aesthetic line, the right dorsal aesthetic line, and then straight down the center.
It is entirely tactile. You have to rely on your hands as much as your eyes.
It's about feeling what you can't always see through the blood and the glare of the OR lights. You are feeling for microscopic residual irregularities under that redraped skin envelope.
Yeah. And while we are working on the septum, we have to establish the most absolute rule in rhinoplasty.
The L-strut rule.
The L-strut rule. When you are harvesting septal cartilage for your structural grafts, you must always, without exception, preserve a solid 10mm L-strut dorsally and caudally.
I always tell residents to think of that L-strut like a load-bearing structural beam in a house. You can hollow out the walls, you can take cartilage from the center of the septum, but if you shave that dorsal or caudal beam, down to 8 millimeters.
The roof caves in.
Yep.
You are buying yourself a textbook saddle nose deformity. It destroys the structural integrity of the entire middle vault.
Okay, so the dorsum sets the profile, but the tip is where rhinoplasty truly succeeds or fails. It's an incredibly complex, dynamic, three-dimensional structure.
Which is exactly why we rely on a strict algorithmic approach to tip refinement. You don't just open the nose and start throwing stitches randomly hoping it looks better.
Right, you follow a predictable escalation of techniques.
Yeah.
The algorithm almost always starts with the cephalic trim. If you need to dial in some tip rotation, or you need to refine a boxy, bulbous tip, you resect the cephalic portion of the lower lateral cartilages.
But there's a hard stop here. You always leave an intact 6 millimeter rim strip.
That 6 millimeter strip is your structural foundation.
Yes. If you get overzealous and resect past that, the alar rim eventually collapses, the external valve fails, and the patient literally can't breathe when they inspire.
That's rough.
It is. Once you have done the cephalic trim, the next step in the algorithm is suturing. Suture techniques are elegant because they are non-destructive.
They reliably produce an increase of 1 to 2 millimeters of tip projection just by altering the geometry of the existing cartilage.
Right. You have medial crural sutures to unify the crura and fix any flaring at the base. You have interdomal sutures to pull the middle crura together and narrow the interdomal distance.
And you have transdomal or intradomal sutures that run straight across the domes.
Transdomal sutures are incredibly powerful for tip refinement. They really define that tip-defining point. But they carry significant risks.
I've seen residents struggle with this. How do you avoid the dreaded pinched tip? Or, the nightmare scenario of an exposed suture extruding inside the nasal vestibule weeks after surgery?
Here is a technical pearl that saves you from both. Before you throw a transdomal mattress suture across the dome, you must hydrodissect the underlying mucoperichondrium right off the cartilage.
So you inject local anesthetic directly under the perichondrium.
Exactly. That physical volume of fluid drops the mucosa away from your needle path and prevents inadvertent intranasal suture exposure.
That's brilliant. But what happens mechanically to the cartilage if you torque that suture down too hard?
You ruin it. Never over-tighten. If you cinch that transdomal suture down too hard trying to get maximum definition, you create an unnaturally sharp, pinched point.
It immediately looks operated on.
Yep. You want to bend the cartilage to create a natural dome, not break it.
Got it. So we go from sutures to struts. Step 3 in the algorithmic escalation is the Collier-Meller strut graft. You usually fashion this from that septal cartilage harvest we talked about earlier.
Yeah, you dissect a precise pocket between the medial crura and set the strut. It controls the Collier-Meller profile and acts as a central, rigid pillar to support your tip projection.
And you stabilize it with a transverse needle, throw your medial crural sutures directly through it, and lock it in place.
Right.
What if you do all of that? You do the trim, the sutures, the strut, and you step back and realize you still don't have enough projection.
Then you escalate to the final tier of the algorithm, nasal tip grafts.
Okay, so you have onlay grafts, which are usually placed right over the domes.
Yeah.
You have the infratip lobular graft, which is the classic shield shape, used to define the infratip and push the projection further out.
Yes, and for your really challenging cases, those thick-skinned patients with the winter quilt envelope, you need massive projection. So you use the combination graft.
The combination graft is an absolute workhorse.
It really is.
Yeah.
It blends the onlay and the shield graft into one solid piece. Superiorly, you anchor it all the way up to the upper lateral cartilages. Inferiorly, you secure it to the caudal margin of the medial crura.
It acts like a heavy-duty tent pole.
Exactly. It provides enough rigid structure to push right through that heavy sebaceous skin envelope and actually show definition.
So once you've reestablished the tip's projection and smoothed the mid-vault, you often realize the bony vault no longer matches the new structural harmony. Form has to follow function here.
Always.
Reshaping the cartilage often means we have to mobilize the bones, but the patient still has to breathe.
And this is where osteotomies come in. We perform percutaneous or internal osteotomies to narrow the lateral bony walls or to close the open roof deformity that we naturally create when we reduce a large dorsal hump.
We have a few distinct pathways for this. The low to high osteotomy starts low at the piriform aperture, which is the pear-shaped bony opening of the nasal cavity, and ends high on the dorsum.
Right.
Then the low to low continues low along the base of the bony vault. And you have the double-level osteotomy for cases with severe lateral wall convexity.
But regardless of which pathway you choose to execute, there is one non-negotiable anatomical landmark you must respect: Webster's triangle.
This is a critical functional point. Where exactly is it visually?
It is the bony triangular area located at the caudal aspect of the maxillary frontal process. You absolutely must preserve it.
What happens if you don't?
If you start your lateral osteotomy too low and fracture right through Webster's triangle, you medialize that bone into the airway. You completely destroy the internal nasal valve.
Wow.
Yeah, the aesthetic result might look appropriately narrow from the outside, but the functional airway is ruined. They literally won't be able to breathe through their nose.
That's terrifying. Let's talk about bony complications. The rocker deformity is a classic one.
Oh, it is a classic frustrating complication in the OR.
Right.
It happens when you are performing medial osteotomies.
Right.
If you place your osteotome too far medially, you hit the incredibly thick portion of the frontal bone. When you strike the mallet and complete the fracture, the bone literally kicks out laterally.
Like a seesaw.
Exactly. It rocks on a fulcrum. It ends up visibly widening the upper dorsum instead of narrowing it.
So how do you adjust your technique to avoid hitting that thick bone?
You avoid the rocker deformity by strictly following a superior oblique angle with your medial osteotomy. You deliberately fade your path laterally before you hit that dense frontal bone.
That makes total sense. Another major pitfall is taking the osteotomy too high up the nose.
You should never extend the cephalic margin of any osteotomy higher than the medial canthal ligament.
Why is that limit so strict?
Because the bone above that intercanthal line is incredibly thick. It makes the fracture unpredictable and technically very difficult to control. But much worse, going that high puts you at direct risk of causing an iatrogenic injury to the lacrimal system.
Meaning you crush the lacrimal sac.
Exactly. You crush the tear drainage system and you leave the patient with permanent epiphora or excessive tearing down their face.
Oh, man.
Yeah, that is a functional disaster that requires a complex secondary surgery to fix.
Okay, so the surgical execution is complete. The anatomy is respected. The functional valves are intact. Yeah. But the operation definitely doesn't end when the patient leaves the OR. Managing the healing process and the patient's real-world expectations is the final hurdle.
The immediate post-op reality is intense for the patient. You really have to prepare them for what those first few weeks actually look like.
Routine post-op includes a Medrol dose pack for 7 days to aggressively manage that facial edema we talked about. Continuous saline spray is vital to manage the intranasal congestion since they have splints in place.
Right.
And there is a very strict real-world rule about heavy eyewear. If they wear thick glasses, they're literally taping those frames to their forehead for 4 solid weeks.
You cannot have the weight of heavy glasses resting on newly mobilized nasal bones.
No way.
The bones are floating. That weight will slowly push the bones inward and undo all your precise osteotomy work in a matter of days.
What about the reality of revisions? The national data shows revision rates generally sit below 10% for board-certified plastic surgeons.
And when those revisions do inevitably happen, they usually stem from 2 specific errors in surgical judgment. The first is undercorrection from being far too conservative during a primary procedure. You leave too much bulk.
And the second?
The second, and much more difficult to fix, is overzealous ablative resection.
Right, taking too much cartilage and destroying the support.
Exactly. Taking too much septum, over-resecting the upper laterals, or crushing the lower lateral cartilages. The structural component techniques we discussed today, sparing the upper lateral cartilages, using autospreader flaps, incremental reduction, and rigorously maintaining that 10mm L strut, these are exactly the concepts that keep you out of the revision OR.
It all comes back to respecting the structural integrity of the nose. You build a strong foundation, you don't tear it down.
Yep.
Well, we've walked through the millimeter by millimeter reality of modern tissue-sparing rhinoplasty. We respect the tissue planes, we preserve the structural struts, and we build upward rather than just ablating downward.
It's a completely different mindset.
It really is. But here is a final thought for you to mull over before your next clinical consult. As we perfect these autologous cartilage-sparing techniques today, how will the rapidly advancing field of 3D-printed autologous cartilage frameworks completely redefine the limits of primary rhinoplasty in the next decade?
That's the real question.
When we no longer have to rely on harvesting limited septal or rib cartilage to build our foundational grafts, how far can we push the structural paradigm?